Andrea Durbin. I am calling in from the ancestral and unceded territory of the Coast Salish people. That's Musqueam, Squamish, and Tsleil-Waututh. I'm a public health nurse. I've been a public health nurse in BC for 30 years. I've worked in 3 of the 5 regional health authorities. I've worked for the Ministry of Health and the BC Centre for Disease Control, which is where I am now. It's an honor to be here today. So thank you so much for having me. I look forward to this. Thank you.
That's a great introduction. Thanks, Andrea. My name is Ajit Johal. I'm a community pharmacist with a special interest in immunizations. Some of you may recognize me from last fall's webinar on influenza. Always happy to work with the BC Lung Association. And just like Andrea, I have a passion for vaccine education, and I am also ecstatic and happy to be here today.
Great. So just want to remind everyone, if you have questions for our panelists, you can use the chat box or under reactions. If you click on reaction, there is a raise hand. So you could use that. And then we will basically, if you do raise your hands, I will unmute you and you can ask your question in real time. So I do have, I'm going to share my screen so I can, because we did get some questions ahead of time. So I hope you all can see that. Yes? Can you see the slides on my screen?
Yes, we can, Maria. Yeah.
All right. Okay, so let's get started with the first question. Okay, so what are the different types of COVID-19 vaccines currently available in Canada? So we'll get started with Andrea, and then Ajit, if you have anything to add, and vice versa.
Sure, Ajit, is that okay? I'm happy to defer to, okay, I can go, all right. So currently there are only 2 vaccines that are licensed for use in Canada, and both of them are the messenger RNA vaccines. These are a brand new platform in the field of immunization. We had preliminary data and some studies specific to MERS, so the Middle Eastern Respiratory Virus, as well as SARS-CoV-1, which is the severe acute respiratory syndrome. The first time that we had it and saw it that in Canada was in 2003. And so there were vaccines that were in the pipeline at the time, but then as you probably all remember or know, that both of those diseases just petered out on their own. And so the vaccines did not make it into the phase 3 clinical trials. But so, it's not a brand new idea, but to be rolled out on this kind of level, it's a brand new platform. That being said, they're highly immunogenic. In the trials, the vaccine efficacy was approximated 95%, which is amazing. So yeah, those are the only 2 vaccines we have right now licensed for use in Canada.
Yeah, no, I think that's very comprehensive, Andrea. Just want to also add that Health Canada is one of the most highly regarded regulatory review processes in the world. So there are other vaccine candidates that are being reviewed, but these are the 2 that are currently approved based on their safety and their effectiveness.
Would you like to take us through the slides first before we answer the chat, or would you like us to
Yeah, no, I do have another, we will go through the slides. There are 10 questions or so.
Okay, cool.
Yeah, okay, so what phase is our province in with the COVID-19 vaccine rollout? When can we expect the vaccine to be available to the general population?
I think you're up. Is that how we're
doing
it? Okay.
Sure. Yeah. No, I believe we are in phase. I think
phase
we're in
1.
phase.
Yeah, we're still
phase
in phase
1. We're still in phase 1. In terms of the rollout to the general population, I mean, it is a bit of a moving target. It's highly contingent on supply. So I think it's been hypothesized, the general population, it'll be an age-based criteria. So it won't just be massively available to the general population. It'll be starting with those who are older And then as that cohort gets immunized, it would go down to the younger population. It is constantly changing. So, I mean, I could tell you what the website is saying, but that's kind of what the plan is so far.
I have nothing to add, so I think we can move to the next question.
Great, yeah. Oops. Okay, so can you still get COVID-19 even after you have been vaccinated? Or can you become a carrier of COVID-19 and make others sick even after you have been vaccinated?
Yeah, this is an excellent question. So yeah, folks can get the disease after they've received both doses of the vaccine, even though the vaccine is highly effective. I think it's important for people to understand the difference between vaccine efficacy and vaccine effectiveness. So efficacy is what we observe in the clinical trials, which are really controlled, right? So people are they're monitored by a nurse at least daily, up to 4 times a day, to get phone calls, any questions, those types of things. And they're really on high alert about what's going on for them. So it's not unusual to see a really high vaccine efficacy in the trials, and then we can see maybe a lower effectiveness when we head out into the real world. So we don't know for sure yet what the vaccine effectiveness will look like, as we're just starting to roll it out, but we hope and think it'll be very, very good. That being said, so to answer the question, yes, no vaccine is 100%. And so folks, you can get the disease after. Now, that being said, some vaccines can reach up to about 100% efficacy or effectiveness in protecting people against severe disease. And I have a feeling that these vaccines might get us closer to that target. I'm speaking of the mRNA vaccines, and we know that, yeah, they're just working really well. Now, the next question is another excellent question. And to be honest with you, scientists still don't know the answer to this. And that is that, does the vaccine, so the vaccine we know protects us, right? We know that if I have the vaccine, that I have circulating antibodies that are ready to fight the virus anytime I'm exposed to it. What we don't know is if there will be enough antibodies in our nasopharyngeal or upper respiratory tract to neutralize or stop it, so that I can't sort of breathe it in and carry it out and onto other people. So a good example is the polio vaccines. So I don't know how old folks are on this call, but I'm really old, and I received the oral polio vaccine as a child. This is a vaccine that is still used in some parts of Africa, and it's because not only does that vaccine protect the individual from polio, but because of its mechanism, it also eliminates asymptomatic carriage and transmission, which means that it stops the virus from transmitting between people totally, which is profound. And that's what we are really hoping for with the COVID vaccines. We're hoping that it will eliminate this state where people can carry it and pass it on to other people, but we don't know that for sure, and we continue to monitor that.
Yeah, no, that's a very comprehensive answer, Andrea. I think I just wanted to highlight some key things you mentioned. The first one being, the vaccine is the key thing about it is to reduce that severe illness. And I think there's everyone's kind of getting different numbers of efficacy, and I like how you went through efficacy and effectiveness. And the numbers that we're getting in the news that the everyday person's getting is that efficacy of the vaccines that are currently approved, but also vaccines that are in the pipeline as well and are being reviewed. So I think it's important for everyone to kind of consider how we look at this from a public health perspective, in that if we can reduce the impact of this disease, and even if you still can get sick after you've been vaccinated, there's a lot of considerations, like when the trial was run, trials that were run later, they could have had the variant circulating in there, and even the sort of cases in the trials, they're measured in different criteria. So even if somebody does get COVID-19, we really want them to not have a severe outcome, because that's we're afraid of with our lockdowns, and that'll overburden the hospital the system. In terms of becoming a carrier of COVID-19, I definitely agree. That's a very difficult thing to measure. Over time, we hope to get some of this information. I know in Israel, there's a few studies being done, just given that their population is being immunized faster, so they can kind of measure some of this data. In the UK, they're looking at people in households who one person's been vaccinated. Is there a difference before that happened and after? So we're going to see a lot of this information come out, but we do recognize it is a very difficult thing to measure.
Okay, so are we going to see more single dosing versus 2 doses to get more people the initial projection? And what is the evidence regarding the efficacy of single dose versus double dose?
Yeah, so that's a great question, and it's to get more people the initial protection. I think the big thing is looking at sort of that public health perspective. So again, going back to Andrea's discussion of efficacy and effectiveness, that's exactly what is being showcased here. So in terms of the efficacy in the trial, a couple things of the approved vaccines. So the Pfizer vaccine is the one we have in most supply that we're doing at a lot of our clinics in the hospital, is that the key thing to note is that we want to look at the attack rate, the difference between the vaccinated group and the placebo group, in that 12 days after that first dose. So we do it from day 0. It still takes about 10 to 12 days, as typical with many vaccines, for the body to actually mount sufficient amounts of antibodies. And what you're seeing now is kind of like that extension between first and second dose, because after that first dose and after that 12 days, when the individual develops that antibody, there is quite a good immune response. And in the trial data, there's actually, then you start to see that sort of discrepancy and that difference between the vaccinated group and the placebo group. That being said, though, the 2 doses is important for long-term durable immune protection. So 2 doses is ideal. But I think when you look at it from a public health perspective, the faster we get people vaccinated with 1 dose and they have something versus nothing is kind of taking priority as we get more supply. We might see that change.
Yeah, thanks, Ajit. I'll just add to that this is an excellent question. I really appreciate it. And often with any vaccine program, there are certain things that we can do that we call antigen sparing. And that is when we have, let's say, a virus or a part of a virus that we are trying to replicate in a laboratory, in a lab, so that we can put it into a vaccine and inject to people. If we don't have a lot of that virus or pieces of that virus, we try to find ways, we try to get really creative in ways to decrease the demand on that amount. And one way is to go from 3 doses to 2, or from 2 to 1. Now, to Ajit's excellent point, while no one is ever recommending at this point that we never do a second dose, what we do know from the clinical trials is that 1 dose in and of itself is really effective for a while. And so, yeah, so when we're looking at trying to protect as many people as we can in a short period of time, which is really important right now with these variants going around, right? We're trying to buy as much time as we can until we get as many people vaccinated. Yeah, but this might, hopefully this will be a process and an approach that the province will pick up on. Next question, please.
Okay, so what is the evidence, if any, for mixing and matching vaccines? So for example, Pfizer for the first dose and Moderna for second dose.
Mm-hmm. Excellent question. And again, I hope one thing that you'll hear me say a lot today is what normally happens in vaccine programs, because I want to situate you all into the context of how we run immunization programs in BC. And this question of, can we mix and match different types of vaccines against the same disease, is a really common question. And the answer always at the beginning is no, we don't, because we don't know. We don't have those head-to-head trials where they give people in the trials, they'll give them right? They'll give some people 2 doses of the same vaccine, and then another group of people different doses, or one, say Pfizer, and a different one of Moderna, to see what their immune responses are like. And that data does not exist. And so at this point, the recommendation is to not to mix them. You can't combine them.
Yeah, no, I definitely agree with Andrea's sentiments there. I think that we don't have data, the relative novelty of these vaccines. We can't say for certainty if we can mix and match. That being said, though, I think that going back to also what you said, Andrea, about having to get creative and improvise in having to deal with this pandemic and how much this virus has constantly been changing and eluding us, is that scientifically, a lot of these vaccines could, in theory, be interchangeable. And even not even with the mRNA vaccines, but also with different mechanisms of action that have been used in Ebola vaccination programs. I think they call it heterologous prime boosting. So there is a lot of research being done. I think it's encouraging for everyone to know that this is being looked into, so that there are contingencies based on what we have and what we're facing with this virus.
Okay, so do the Pfizer and Moderna vaccines protect against new variants of COVID-19 that are spreading around the world?
Yeah, this is an excellent question. It's probably unfortunately, the most burning question. As soon as in December, when we saw these vaccines being approved, we started hearing about variants and wondering how that would, are we too late, and do we have to change the vaccine? So in terms of the target of the vaccine, it does target the SARS-CoV-2 virus, the spike protein. And it has, fortunately, with these approved vaccines, there's multiple targets on the spike protein. As of now, it is seen to be still effective against this variant. And the good thing, though, is that in this constant race between vaccine and variant, with this mRNA technology, what it is a set of instructions. So the good thing is there's not a lot of changes that need to be done from a research development side. If it does become sort of less or ineffective against the variant, eventual mutation of the virus, those instructions can be changed. So it offers a very nice, elegant platform to adapt and kind of roll with the punches that this virus could throw at us.
Andrea, do you have anything to add, Andrea?
No, I don't think so. Next question. Thanks.
All right. So is there any evidence for use of COVID-19 vaccines in youth or kids?
Good question. So the hard answer for the mRNA vaccines is not under 16 years of age. Kids 16 and above were included in the Pfizer and Moderna studies. I can't remember who had 18 above and 16 above. It doesn't matter. What is important, though, is that, again, we do this with vaccine programs. So, for example, with the HPV vaccine, so the HPV virus is the cause of cervical cancer in young women. And when we were rolling out those vaccine trials, obviously it's unethical to do pelvic examinations on 9-year-old girls. And so what we were able to do is what we call bridging studies, and that where you're able to look at different aged populations and make sort of a best guess on how the vaccine will work in a different age. Now we did it the other way. So we were able to, we did it the same way where we immunized older women, and then we were able to guess that the vaccine would work as well in younger women without having to expose those young girls to pelvic exams. So the same thing will happen here for the mRNA vaccines right now. Again, the kids were not included in the original trials. Whether or not the bridging studies will go ahead or whether they'll just be expert opinion at this point, I don't know, Ajit, I don't know if you know, but as other vaccines roll out with platforms that we've used forever in public health, those will be easier to study in kids.
Yeah, no, I think that's a great answer, and I really liked your connection with the HPV vaccination example. From my understanding, with Pfizer's initial presentation at the FDA VRBPAC review, there were plans to do immunobridging among co-administration with the influenza vaccine, which I think there's a question coming up on co-administration of vaccines, but we'll save it for that. So there is talks from the manufacturers and the researchers to look at that. And also at this time, it's what we know about the virus. Youth and kids don't seem to be a significant source of infection or transmission. So it really we should focus our priority on vaccinating those who are at high risk and follow the program. And hopefully by the time everybody's vaccinated, those immunobridging studies will have started and we'll have some more information.
Is there any testing to verify a person's immunity response to COVID-19 vaccine? So for instance, I was tested for hepatitis B and now I need a booster.
Yeah, so that's a really good question because it kind of goes to the efficacy and the effectiveness piece as well. So usually, like in the trial of the vaccines, even before the actual two arms were set up, there was sort of these trials to assess the antibody response as sort of a surrogate of protection. At this time, there is no test to test immunity to the vaccine. What there is, so at the vaccine clinics, what we do screen for is if anybody's had COVID-19 disease before, because there's two ways you can make antibodies. One is you can get vaccinated, or two, you can get the actual disease, and obviously getting vaccinated is a lot better for you. But if someone's had COVID-19 disease, they do have antibodies as well. And fortunately, in the trials, in the Pfizer trial, people who've been tested positive for disease and had antibodies are included. So it's still safe for them to get it. The problem is that they do make antibodies for up to 3 months. So in that 3-month period, the risk of reinfection is quite low. So what we're doing now from public health, what public health is doing is that they are basically, in terms of supply, anybody who's had active COVID, lab-confirmed COVID-19 disease in the past 3 months, they're delaying their immunization until after those 3 months because the risk of reinfection is low. And given the supply of the vaccine, better to use that vaccine for somebody who has nothing. So I think I hope that answers the question in terms of testing immunity. It's an important feature, but as of now, I'm not aware of any tests for confirming immune response to the vaccine.
Yeah, thanks, Ajit. I'll just weigh in, and I would not be a good public health nurse if I didn't say that for anybody with a hepatitis B vaccine series, if anyone's going to bleed you, take your blood to see if you have antibodies. Unless your antibody test is 1 to 6 months after your 3rd dose of hepatitis B, that is a false negative. So what I'm trying to demonstrate here is how fraught testing is to see if someone's developed an immune response to a vaccine for a lot of reasons. And as Ajit very clearly laid out for you, that it's what we call correlates of protection. How do I know that the vaccine worked? How do I know how many number of antibodies do you need before I can know for sure that if you're exposed to the virus, you won't get sick? So with hepatitis B, the scientists came up with the number 10. So 10 international units per mil of blood. So we know if you've got that you are considered immune. With COVID-19 disease, let alone the vaccine, scientists have not agreed on a correlate of protection, which means we don't know the number yet that we need people to have before they're considered immune. Now, unfortunately, me and my entire family got COVID over Christmas. My parents are still in the hospital. It's been devastating. And the antibody response, we can't determine. We've had point of care tests that tell us that we have antibodies. We had the nose swab that showed the virus. It was a PCR thing where we could see the virus. But whether or not our antibody levels are really high, how high they are, how long they last, after a vaccine or not, we don't know. Next question, please. I'm just looking at the time, and these are great questions. How long after receiving, oh, sorry, Maria, go ahead and read it.
Yeah, go ahead. How long after receiving COVID-19 vaccine do you need to wait before getting other immunization?
Thank you for asking this question, whoever did. And so the answer is 28 days after your COVID-19 vaccine. Now, if any of you have any other vaccine, like a flu shot or shingles or a pneumo shot or whatever, and if you then get the magic call to come in and get your COVID vaccine, even though you'll read online that there is a recommended amount of time that should be put between the receipt of a different vaccine and your first COVID vaccine, don't worry about it. Because what was happening, unfortunately, is some people were being turned away from COVID-19 vaccination clinics because they had their shingles vaccine last week. And that is absolutely not okay. Now, the people that were turning them away were just concerned at the lack of data around safety and interactions with other vaccines. However, we are not concerned about that. There are no biologically plausible reasons why it would be dangerous. And we know, to Ajit's point, when we're looking at benefit and risk, that the risk of COVID-19 vaccine far outweighs any risk of the COVID-19 vaccines at this point, particularly in our senior populations, particularly in people who are in long-term care. So all that to say, if you're called in to receive your COVID-19 vaccine, make sure you get it, regardless if you've had a previous dose of a different vaccine. But there are certain time periods that you should try to honor if you can, if you're planning ahead. But if you're not planning ahead, don't worry about it. Ajit, I don't know if you want to add anything to that.
No, I think that's really good. I think you really highlighted something that's happening right now. And I know the National Advisory Committee does set out a guideline of 14 days before of a vaccination, before your COVID-19 vaccine. But even in the Q&A we put on our immunize.io website, and even in clinical practice, there's two clear messages. And the second one, Andrea, you alluded to. If you had a vaccine a week ago, 3 days ago, 5 days ago, do not turn away your COVID-19 vaccine appointment because of the risk and the benefit. This is a very sort of conservative recommendation, just because people just want to plan ahead. And the other thing I want to mention is that a lot of us don't know when we're getting our COVID-19 vaccine. So that should not mean we don't update the immunizations that are still important for us. A lot of these immunizations, if we start our first dose of our Shingrix, if we start our first dose of our HPV vaccine, if we start our first dose of our Hep B, these multi-dose vaccine series, we can start those. And if we get called for COVID-19 vaccination, we can always defer it. We can always extend it. So this isn't sort of a blackout period where we don't care about any other immunizations because we have to preserve this period before COVID-19 vaccination. We go ahead with best practice and what's best for our health on that particular day. And if you're called in for COVID-19 vaccination, don't worry if you've had immunizations before, and don't stop immunizing now for other diseases. Okay, so the next question is, are there any other COVID-19 vaccines, such as the one used by Johnson & Johnson, being used in Canada? So as of now, it's not being used because it's not approved. So the Johnson & Johnson vaccine and the Oxford AstraZeneca vaccine are two candidates that are being reviewed by Health Canada. So they're being reviewed by our regulatory body for safety and effectiveness. So they're kind of in the queue for potential use in the population. So it's not saying they'll never be used. They're being looked at right now. So it's being put under consideration.
Yeah, so let me just see what we have in the chat in terms of questions.
Maureen.
Okay, let's see. what happens when an oh wait, I think we've already answered that. Is there any reporting on whether or not the variant patients have been vaccinated?
You know what? I don't know, Ajit, if you've heard of that. I have not, and that's an excellent question. I don't think so, because the variants have been detected, I don't believe, in long-term care facilities. And right now in BC, that the only folks that have been, well, people that work in long-term care assisted living or in acute care, people that work there as well. But that's a good question. I don't know. Ajit, do you know the answer to that question? Where are you?
I think that is a difficult question, because I think even in Canada, we don't know where this variant is or in what quantity it's even here. The best sort of analogy I can think of is one of the arms of the Oxford AstraZeneca trial, where it was actually in South Africa, and that's where the so-called variant originated. So, and you do see a little bit of a drop in efficacy in that trial. So I think the main thing is, like, at the end of the day, we can't control how this variant is going to evolve. But the one thing about variants is that what allows them to mutate and evade our immune system is allowing them to infect us more often and for longer. So the faster we vaccinate our population, then the faster we can, kind of stop the spread of this variant and stop it from being a variant in the first place. And yeah, I see variants are coming from England too. Yeah, that's another location. The South African variant, from what I've understood, is a little bit more of a variant per se. And in that, the variant's key thing about it is it's a bit more contagious from what they've seen. So yeah, I think that's what we can deduce from that.
Maureen, I'm just looking in the
Yeah.
chat.
Go ahead. Yeah.
I see there was one I don't think we answered. One is, will the vaccine be a yearly shot like the flu shot is? And we don't know. Great question. The answer is absolutely probably. Unless this virus just mutates itself out of a job, I can see this becoming an annual vaccination. And again, it depends on how much the virus changes. So if the virus is quite stable, like measles. So a measles virus is so stable that with this, we're using the same vaccine we introduced in the 50s and 60s. It's the exact same virus because it's such a stable pathogen. But this pathogen changes a lot, like influenza, not as much as influenza. But to Ajit's point earlier, with this new platform of mRNA vaccines, maybe, maybe the genetic material will be enough to sort of handle any mutations that happen. We won't, so that's why I'm saying we don't know. But I'm thinking likely, if I had to answer this question, for $1 million today, my guess would be, yeah, it'll probably be every year. I'll take the next one too, Ajit, just because I'm supporting the nurses on Immunize BC, and we get this next question all the time. This is from Mari. Are people with lung conditions getting the vaccine earlier than the age group? Now, great question. On the website that Ajit was talking to, that folks who are considered, and the 3 words they're using are extremely clinically vulnerable. And that applies to people with severe asthma. And so we were researching this week. You folks could teach me way more about this. What is the definition of severe asthma? And if someone's been deemed as a client with severe asthma, then how do they access those immunizations? And maybe folks around this table know more than me, but we, all I've been able to say to the nurses to reply to the patients is to say, discuss this with your healthcare provider immediately. And I would, on the website, the BC Ministry of Health has a website around immunizations, and there is a place for all of us to register, to be contacted when it's our time. And so I would recommend that you go on that website and put all your data and information in there.
Great, thanks for taking that question. Let's see the next, I've kind of lost it in the chat here. I think it's what happens when an asymptomatic COVID person gets the vaccine while they're already active. So I guess if somebody's asymptomatic, they already have the virus. So, we're not doing a lot of asymptomatic testing. The testing is being triggered by symptoms. So if somebody is asymptomatic and they didn't know, then I don't see an issue for them getting the vaccine. If they are symptomatic and they test positive for COVID, they would need to wait before getting the vaccine, obviously. So I hope that answers the question.
I do have one question actually that we missed with the PowerPoint that we're sharing. So I'm just going to share that right now. And it's the one about the Novavax.
Also, sorry, Maureen, I just want to let folks know that I put the link to the province's immunization plan in the chat box for people. Could you tell us how to receive the Novavax vaccine, which I heard is a more traditional type? Yeah, wow, these are really informed questions. Yeah, no, it hasn't been approved for use yet in Canada. And so there's absolutely no way for you to get it at this time. Yeah, I don't know, Ajit, if there's something you'd like to add to that.
Yeah, I guess, Andrew, I guess my concern with this question is this sort of vaccine preference, saying I want a more traditional vaccine, I don't want the mRNA vaccine. I think we should be confident in the safety and the effectiveness of all vaccines that are approved. And I had like a little diagram, but I think in the interest of time, I won't share it. But essentially, regardless of how the message is delivered, what's happening is your body's making antibodies against the target of the virus. So traditional vaccines do the same thing. mRNA vaccines is just one little extra way it goes inside the cell. It doesn't go inside the nucleus. Your body makes the proteins themselves versus sending the proteins for recognition. So all of these vaccines kind of do the same thing. They have the same end goal. And then the other thing is, I know even my own mother told me, she wants the mRNA vaccine, and the Oxford AstraZeneca vaccine, that's only about 70% effective. So that's for you young people. And the message, I mean, what I say about that is, whatever vaccine you were able to get on that day, like Dr. Mike Ryan says from the WHO, is the best decision you can make for your health. We're all in this together. We will take any safe and effective vaccine. Getting immunized by it will help us reach herd immunity so that we can, have these sort of meetings in person eventually. So I think that's the key thing is just trust in science, trust in the great folks at Health Canada who are constantly looking at the safety and effectiveness of vaccines so that it's safe for you. And whatever you get the call, whatever vaccine you get inoculated with, remember it's better than what you had before, which was nothing. So that's kind of
Maureen, I saw one more question in the chat, and it's the question about if someone has COVID disease and doesn't know it because they are asymptomatic and they don't have any symptoms, and then they get vaccinated, is that a problem? And although that hasn't been studied, the answer is no. Like there's to Ajit's point, there's no sort of scientific reason that would be problematic. However, it is being followed and monitored. And what we've seen so far is that people that potentially were incubating and then got vaccinated, there was no severe illness outcomes or any of that. So it was fine. That's a great question. Thank you. So Maureen, is there do you want to have,
Yeah, go ahead. Yeah, if anybody has any other questions, like I said, you can use the raise hand function or type it in the chat, or you can unmute yourself if you want to just ask a question right on the spot.
Ajit, do you want to take that next question?
Yeah, it says, are vaccines going to be available for immunocompromised people? So this is actually a really good question because it addresses a lot of the, I guess, groups that were not included in the clinical trial. So that's unfortunately the challenge when we have these large trials and we've got to get these vaccines quickly on a pandemic timeline is that it's tough to include the special populations like immunocompromised, pregnant, breastfeeding populations. So what we have to do is look at it from a risk-benefit perspective. We know that those who are immunocompromised are at higher risk for bad outcomes of the infection. Same thing for those who are pregnant, disproportionately at risk. So scientifically, we know that none of these vaccines are actually live vaccines. So that's always a challenge we see with immunocompromised in pregnancy. If it's a live attenuated virus in the vaccine, it's a very weak form of the virus, which wouldn't be an issue for those who aren't immunocompromised, but if they are, then it can cause some challenges. Fortunately, with these currently approved vaccines, like I said, it's a set of instructions, so it's no actually live piece of virus. So scientifically, we can hang our hat on that. In terms of immunocompromised, really what I kind of look at is some of the guidelines that are put out by some of the specialist groups, so rheumatologists, and really it comes down to a risk-benefit sort of discussion with your healthcare providers. So it shouldn't be taken lightly. You should talk to your healthcare provider about that. But once we start to go up in age, so if over 70, over 80, and you're immunocompromised, the age thing clearly overrides it. Clear that you should be vaccinated. So hopefully that answers the question. I don't know if Andrea, you want to add anything?
Yeah, I just want to, just to hopefully that folks will feel, just to be really clear, that we're not concerned that the vaccine is dangerous for people that are immunocompromised. The concern that we always have with our immunocompromised folks, we're always concerned with live vaccines and being immunocompromised. That can get you in a lot of trouble. Inactivated vaccines in folks that are immunocompromised, whether it's sort of organically or because of medicines, our only concern is that the vaccine won't work as well. It won't be as protective. Yeah. Sorry, I'm just trying to get on top of these. Do we need to register to receive the vaccine? Well, it depends. There is a place on the website. So I had sent it through actually to Madi privately. Thanks, Ken, for sending it to everybody. So that's a good catch. Yes, if you go on the website that's in the chat, there is a place. I don't think you need to register. You might be able to have this conversation with your specialist or your GP, or even phone your local health unit and find out. But for folks that are quite anxious and really want to make sure that that you get the vaccine at the first possible time, I would go online to register.
It's a good point. I think the online booking is what they're going for. There's also another question: is there a recommendation to wait a certain time after getting the vaccine before getting and trying to get pregnant? That's a great question, actually. I got this question a month ago or so, and it was based on the actual Pfizer clinical trial protocol, where they advised people in the trial not to conceive for 28 days or use backup contraception for 28 days. And where that comes from is sort of that, again, when we look at what me and Andrew were talking about with live vaccines, is that sort of that time where we get that sort of interferon response from a live attenuated vaccine, and that people should delay pregnancy for 4 weeks after getting those types of vaccines. So remember, these trials are very conservative. They want to make this vaccine as safe as possible. Now, there were quite a few people in the Pfizer trial who, they didn't abide by this. So there's quite a few of them who did get pregnant and who are in the trial. They're being closely followed. There's no issues. The one big thing, though, is there is a very dangerous piece of misinformation where they talk about, and again, Andrea knows this too well, about the internet's good for, information, all sorts of information, whether it be good, bad, or misinformation. So there was this sort of, and I don't know if anyone here has read it or has concern about it, is I'm always concerned with something of soft science. So things that look scientific but are actually inaccurate. So like, Bill Gates trying to spread COVID-19 through 5G networks, a lot of us can kind of say, that's misinformation. But for the pregnancy piece, there was this sort of, there's this protein that allows adhesion to the placenta. And I may be wrong what exactly it does, but there was this sort of misinformation around it. It looks like the spike protein. It looks like the spike protein, so therefore your body's going to make antibodies against that. And that's completely false. It is nowhere near similar in structure, nor will it even go, the antibodies will even go to that place. It's, again, totally safe to get the vaccine. If you're trying to conceive, you go for the day of your appointment and just continue on. So I thought I'd mention.
Thanks, Ajit. I think there was one more question. Oh, also, I am so sorry, Judy, thank you for pointing that out to everybody. It is March. Well, it doesn't even say March 1st. So sorry, I just told everyone to go register on the BC Ministry of Health website. It doesn't open until March, and it doesn't even say March 1st. It just says March. So I apologize about that. Yeah, and also just to let folks know, thanks for the prompt, Elizabeth, that BC Care is hosting an event tomorrow open to all seniors in BC and their families and caregivers. And it's tomorrow at 10. So, and that's through BC Care. So if folks want to continue this conversation, we have a lovely family that will be there sharing their awful experience with influenza A. Anyways, as a senior, but yeah, so are there any other questions? We really appreciate these excellent questions and discussion. Is there any groups at higher risk of having, Jean, I'll let you take this one.
So I think
That's
this
a tough
one,
question.
yeah, it is a tough one. I think that initially, when the vaccine was first approved, there was an issue with anaphylaxis, and those who have a history of anaphylaxis having some concern with getting the vaccine. Now, a couple of things to that. That has been narrowed down to specific ingredients in the vaccine. So polyethylene glycol, which is a common ingredient in foods, medications. If any of you are old enough to have a colonoscopy, polyethylene glycol, you drink a ton of it before. So it's specific to that. Now, that being said, having worked a few of the COVID-19 vaccine clinics that's currently being done in phase 1, we screen very closely for allergies. And the key thing about an allergic reaction to a vaccine, and Andrea probably knows this better than I do, is that when it does happen, it's medically pretty straightforward to manage. There's aftercare after you get the vaccine. You're monitored for a certain period of time. There's enough ways to address that. The other thing is it's being very closely monitored. Again, Health Canada takes this very seriously, so they're monitoring all sort of severe allergic reactions to the vaccine. In that it's a true allergy. So they actually send people for blood testing at this point in the phase 1 clinics if they do get a severe allergic reaction. Now, keep in mind, anaphylaxis is different than an immunogenic response. And I think, Andrea, you referred to that as well. So some of you may have had the Shingrix vaccine and felt very ill and icky for the next few days. And I always say, that is part of to be expected. We need to wake the immune system up. We need to let it know that it needs to do something above and beyond what it's normally doing. And sometimes that makes people feel a little bit icky. So that's actually not an allergic reaction. That's an immunogenic reaction. So hopefully that's a clarification.
There's a question around the vaccine that's being manufactured in China, and my understanding, and Ajit, please speak up if you disagree with this, is that it's not one of the 7 that's being currently considered by Health Canada. However, there's a last question I think is important. It's also in line with the allergy question, and it's can I get COVID-19 disease from the vaccine? And sorry, when I think of allergies, I'm thinking of our immune systems. And the answer is no, like not with the mRNA vaccines. I think Ajit already addressed this. And that is because that's just the genetic instruction. So you can't, that would be like asking ground chicken to lay an egg. That's exactly what it would be. That won't work. A ground chicken can't lay a live egg. And it's the same thing with our inactivated vaccines. So it can. However, if you have an immunocompromised person that receives a live vaccine, and there are some live vaccines for COVID-19 in the pipeline, that is when the virus could go through stuff in somebody's body to become more pathogenic, more severe, more wild, more dangerous. And that would be the only time that somebody could get the disease from the vaccine. And again, that's not just COVID. That could be measles, that could be yellow fever, that could be, yeah, so.
Yep, I think you've named them all. So the other question I see here is formaldehyde allergy. So, this actually is a really good question because it kind of brings back, and I'm sure Andrea this really resonates with her and in this sort of misconception about vaccine ingredients. And I guess the best quote I can sum that up is from Paul Offit from the US CDC, is it's the amount of toxin, not its mere presence, that counts. So, things like aluminum, formaldehyde, they're not in every vaccine. And if they are, it's in very trace amounts. And I think, in terms of aluminum, it's like 0.85 of a gram in a single vaccine. And by six months of age, most infants have consumed like 1,600 grams or kilograms of aluminum just from breastfeeding. So it's kind of like these trace ingredients, unfortunately, they get a lot of attention, but in reality, it's just because they're present. They're in very trace amounts compared to what we would see eating like an apple or a pear when you talk about formaldehyde, or things like Tums, antacids for aluminum that some of us take more regularly. So I think that's a really key point, because everyone's looking at vaccines, everyone's looking at how important they are, they're looking at all this information. We need to continue this momentum, because the more vaccinated we are, the healthier our community is. So I think that that's an important lesson hopefully we get from this.
Thanks, Ajit. And Maureen, I do have a 2:30, so I'll have to jump off, but Terry had a really great question around his wife getting the vaccine at the same time. And Terry, I'm really sorry to tell you that unfortunately at this point, that caregivers within the home are not necessarily eligible. However, I would like you to keep asking that question because it totally depends on how much vaccine we have in the province. And, you might be lucky. So if you can take your wife with you when you get your shot, sometimes, as this is a really expensive vaccine. It has to be kept under pretty rigorous conditions. And if they have some vaccine left over that's already come to room temp, they're going to want to give it away. So keep asking. It does not defeat it. We, definitely, even if you are immunocompromised, it might not be as immunogenic for you, but it definitely will have any type of protection is better than that.